Dr. Roby is MD, completed internal medicine residency at Johns Hopkins, where he is currently a pulmonary and critical care fellow. He is supported by a T32 training grant, and his previous work as Fogarty Global Health Fellow was focused on implementation of community health worker interventions for TB and HIV patients in Malawi. And his current research focuses on long-term clinical and patient-reported outcomes for critical ill patients with sepsis. We're really honored to have Dr. Flick on board for this presentation. And with this, I would like to invite Dr. Flick to the presentation. And for participants, you can raise your hand for questions and comments anytime. And also, you can drop your questions and comments in the chat box. And let's make the presentation interactive so that we can gain from it. Thank you very much. Dr. Flick, you may start.
Great. Thanks so much, Dr. Kenny. Let me go ahead and share my screen here. All right, so thanks so much for the kind introduction. I'm Robbie Flick. I'm excited to talk to you guys about the clinical implications of antibiotic pharmacokinetics in the critically ill. As Dr. Kenny said, please feel free to raise hand or just drop anything in the chat as I talk. And Amanda or Dr. Kenny, if you could just monitor the chat because I can't easily see it when I'm presenting. I have no disclosures. And a little bit about me, I'm a father to a toddler. I'm a fellow here at Hopkins. I want to make it very clear, I am not a pharmacist. I'm very interested in this area of sepsis and optimal management of sepsis, but I can't claim to be a complete subject expert on pharmacokinetics. But I've done a lot of reading and hope to share some of what I've learned with you. My current research focus is on sepsis outcomes and process measures. Our learning objectives today, I would like to understand the core principles and the vocabulary that we use when we're talking about clinical pharmacology, describe a few common mechanisms for how critical illness affects pharmacokinetics, and I'm hoping we can understand the rationale for why we would use an extended infusion of certain antibiotics and what the current guidelines are for their use. So if you're anything like me, it's been a while since you've done the textbook learning around pharmacology, so I had to dust off some of my old notes and books, and I thought it would be helpful just to review a basic framework for just what are pharmacokinetics and pharmacodynamics to help frame our discussion around how that changes in the ICU, but also to equip you all with some of the vocabulary for when you're looking up your drug information in your favorite pharmacology reference so that you can make sense of what things like volume of distribution and bioavailability, what those actually mean and how they're calculated. So this is just a very simplified framework for just the delivery of medications. Starting in the top left, when a dose is given, we have to think about the absorption of that medication as it gets into the body. Now, we're not going to be focusing on that as much because in the ICU, many of our medications and almost all of our antibiotics are given intravenously, but it's still just part of our pathway. Once something is in the systemic circulation, we think about the distribution of that drug. So that's the movement of drug from the central circulation into the peripheral tissues or compartments. And we also have to think about the elimination of that drug as it's cleared by usually the liver or the kidney. And these all factor into the steady state concentration of that drug. Moving down our figure, we have to think about the concentration at the site of activity, which for antibiotics is usually the bloodstream or certain tissue areas. And then we have to think about the pharmacologic effect, hopefully efficacy and not so much toxicity, but just the last part of our diagram here. And I like this way of dividing it because it helps me remember what is pharmacokinetics. That's the top 2/3, and that's also described as what the body does to the drug, whereas pharmacodynamics classically is what the drug does to the body. So how is the body affecting the drug as it gets into the system, pharmacodynamics, or what actually happens at the target site for that medication. So we're going to go through each of these red terms and do a little bit more detail just to flesh out this framework a little bit. First, absorption, which I told you we're not going to spend too much time on because we're really focusing on IV medications where absorption is 100%. But I have thought, you can think of times maybe you've given enteral medications or intramuscular injections in the ICU. So it's not completely irrelevant. Bioavailability is a term that describes the amount of drug that gets into circulation divided by the amount of drug that's administered. It's always represented as a percentage or proportion, and it's often abbreviated as the term F. Considerations when you're thinking about bioavailability and especially enteral medications. I think these are all pretty self-evident, but important to consider, are you even perfusing the gut? Are you providing enough blood flow that you can reliably absorb something from the intestines? Important to remember that anything that's given enterally is going to go into the enterohepatic circulation. So it's going to hit the liver before it gets to the systemic bloodstream. For some medications, that's either necessary or can cause problems, but it's just an important consideration. And then, we always think about issues when giving meds concurrently. This is especially true with complex medication management in the ICU. And I've seen a few bad situations where people were getting calcium or phosphorus containing solutions like a phosphorus binder or Kxalate, which also happens to bind up a lot of your antibiotics as well. So just a brief overview of absorption, but not something we're going to be spending as much time on. Back to our framework, our next stop on this is distribution. So distribution refers to the movement of drug from the central circulation to the peripheral compartments, to the interstitium, to the surgical drain in someone's abdomen, to the fat tissue, the adipose tissue. The volume is a measure of just how much distribution a drug undergoes, and it's important to recognize it's a theoretical volume. So sometimes you see volumes of distributions reported that are actually exceeding your typical patient volume. To give you some numbers, the typical for a 70 kilogram adult, blood volume is about 5.5 liters, extracellular fluid is about 20 liters. And important to recognize that distribution is a function of really two things. One is the drug characteristic, with the lipophilic drugs having a higher volume of distribution. That's because they bind to fat tissue. Then any drug that has less binding to serum proteins is going to have a higher volume of distribution. This is more just for your background, not anything I would focus on memorizing. Patient factors also play a role that we'll get into a little bit later, but you can imagine your patient in heart failure with 20 pounds, 20 kilograms of extra fluid, it's going to have a higher volume of distribution than someone who doesn't have that extra fluid on board. I put this here. This is kind of a small lie. It's under the header of distribution, but it's really getting at how binding to plasma proteins affects drug availability. And the take-home message here is that it's really only the free, unbound drug that can act on your targets. And most drugs do bind to plasma proteins, mostly albumin, but there are some others. So if you have less plasma protein, so if your albumin is low because you're inflamed or malnourished, you're going to have more active, unbound drug. So less albumin, more active drug. Okay, so that's distribution. We're next going to turn to elimination, which is the metabolism or excretion of drugs. This is really a function of what we call clearance. That's the rate the drug is reduced by specific mechanisms. Mostly renal and hepatic clearance are the most common and relevant. A few notes about elimination. Almost every drug exhibits what's called first-order kinetics. First-order kinetics means that the rate of elimination is proportional to the concentration of the drug. The rate of elimination is proportional to the concentration of the drug. So more drug, faster elimination, less drug, slower elimination. I think we all understand this intuitively, but I just like having a figure to outline it. So on the left, we have our typical first-order kinetics. And as you can see on the left, very high concentration, that slope is pretty steep going down, and on the right, it flattens out. And so this is something that I think is pretty intuitive to us, but I just want to highlight because it has some implications for understanding half-life and a few other measures. I'll briefly say one thing about zero-order kinetics, which is on the right here. A few antibiotics have that, but it's pretty rare, but it basically describes just a steady rate of elimination regardless of your concentration. That's why it's a straight line and not a a curve. So moving on within our topic of elimination, an important concept that's related to elimination is the half-life. This is the time required to eliminate half of the drug present, and it's abbreviated with this T half in subscript. I put the formula for half-life here. I do not want anyone to memorize it. I just want to display what determines the half-life. And as you can see, it's a function of the volume of distribution on the top. So as volume of distribution, as we just talked about, increases, your half-life will get longer, divided by clearance. So if your clearance increases, if you're clearing more drug more quickly, if your renal function improves, your half-life will decrease. I think that's something we all kind of intuitively understand, but sometimes it's nice to have a formula describing it. Why do we need to know a drug's half-life? It allows us to describe a few critical attributes. The most important to me are the time it takes to reach steady state. And that will take about 5 half-lives. Also the time to have a complete elimination for a drug that has reached steady state, and that's another 5 half-lives. It also gives you a sense of how much fluctuation there will be between doses, but honestly, it's a little bit less important. This is a diagram of a continuous infusion, or just a model of a continuous infusion that's it shows how concentration changes as time increases. And it highlights really nicely the fact that it takes about 5 half-lives to get to that steady state. Then if you turn off the infusion at the 5th half-life there, it takes about another 5 half-lives for elimination. I want to highlight the fact that this is not dose dependent. So if you increase the dose, or if you give a bolus faster or slower, it's actually not going to change how long it takes to get to a steady state. It is entirely dependent on the half-life. That's something that I think is actually not intuitive. It feels like you should be able to give more or give it faster and you'd reach a steady state sooner, but that's actually not the case. One way we get around that is with use of a loading dose. So this is a simulated drug concentration curve. The red, these are both of the same half-life, same drug. The red is if it were given with a loading dose followed by an infusion. And the blue is if it's just given as an infusion without a loading dose. And it highlights, I think, what we all know is that giving a loading dose is a great way to achieve a certain concentration while you're waiting for to achieve your steady state. So usually in the ICU, we're not waiting around, what is it, 12, 14 hours here to reach your therapeutic dose. We need to take a shortcut. And this is one way to take a shortcut is by giving a loading dose followed by an extended infusion, which we'll talk about more in a little bit. Okay, so we've talked about distribution, we've talked about elimination. Just a few more things in our review of pharmacology, and that is antibiotic efficacy. One term that's important to know is the mean inhibitory concentration, or MIC, and this simply describes the lowest concentration of an antibiotic that inhibits bacterial growth. You've probably seen this in your kind of microbiology lab reports. So lower MIC takes less antibiotic to kill off the organism in question. Higher MIC, it takes more antibiotic. And then if its MIC is greater than assay, it tells you that you have resistance on your hands. And then the second bullet point is getting at what are called the kill characteristics of antibiotics. And this is kind of a confusing term. I've put this figure here that outlines it a little bit better. And what it's basically describing is that some antibiotics, like aminoglycosides, amikacin, tobramycin, gentamicin, it's all about the concentration you reach. So if you reach a certain concentration, the amount of time you spend at that concentration is less important than actually achieving it. And this has to do with, there's something called post-antibiotic effects, and I think of it as like a bacterial stunning after a big dose of amikacin that gives you a little bit of time before you give your next dose. And this is why a lot of aminoglycosides can be given to 24 hours. The opposite of that would be time-dependent killing. And so a great example is our beta-lactam antibiotics. And that's the bottom bubble there. These are, their efficacy is a function of how long they spend above the MIC. So it's the time above MIC. It's not like they have to reach the MIC, that's kind of their threshold concentration, but you can't just hit it and let it go down for the next 24 hours. You have to maintain it above MIC. In truth, this is a little bit of a false dichotomy. I think both are important, but for beta lactams in particular, it's this time factor is a big deal, and that is really what led to the development of our extended infusion approaches. All right, so we finished our rapid review. I hope that was helpful. I put this slide here to remind myself that in addition to talking about, to providing a framework for our discussion around pharmacokinetics in the ICU, I think this basic vocabulary is really important to equip you with the knowledge for just looking up a drug. If you want to know what the volume of distribution is, protein binding, half-life, I think this is ceftolozane that I looked up, even tells you that it's a time dependent associated with time-free drug concentration above MIC. I think most areas have some kind of freely available pharmacology reference that has some of this basic information. This is all stuff that's required by the drug manufacturer. And so it's available to you. I want to make sure that folks have the vocabulary that this stuff makes more sense than it would otherwise. Okay, so we've talked about some basic pharmacology concepts. Now I want to shift gears and talk about common mechanisms for how critical illness affects pharmacokinetics, especially with antibiotics. And the answer is that it is just awfully complicated. And there are ways that there are avenues that we don't fully understand yet. This is a diagram I really like because it boils it down to the key attributes that critical illness changes and how it changes them. And as you can see, it's really, there are two things that can change with critical illness. You can change clearance, and you can change volume and distribution. So let's talk about clearance first. This is complex because it probably follows a bimodal distribution. What I mean by that is early in critical illness, so think about your patient in distributive shock, you're going to have a relative increase in your cardiac output. And this can lead to higher perfusion of the kidneys and the liver and hyperfiltration in the kidneys, and actually just an increase in your creatinine clearance. So early in most forms of shock, I guess cardiogenic shock would be the exception here, you can get greater clearance than you would at baseline. As someone is sick for usually greater than 48 hours, I feel like we often see acute liver injury, acute kidney injury, and the effect of critical illness starts shifting towards a decrease in clearance rather than an increase in clearance. But if that change happens, when it happens, it's very patient dependent. So how do we manage this? In an ideal world, we would be able to measure active drug levels when feasible. But I think in our setting, it's really only vancomycin, a few of the aminoglycosides that we regularly monitor, or that we can even are able to monitor drug levels. It's always a good idea to have a good estimate of your renal function, but those estimates can be pretty rough. All the calculators that use serum creatinine as an input and try to give you a creatinine clearance, none of them are validated for use in a critically ill population. So our EMR will try to tell you what the GFR creatinine clearance is based on your serum creatinine, and you have to just consciously ignore that or just take it with a large grain of salt because it's probably not going to be a valid measurement. When I was preparing this talk, I read some guidelines that said, yeah, you should directly measure creatinine clearance by getting 12-hour urine collections or 24-hour urine collections for every patient every day. And I think that would break our ICU, honestly. That would be just too much. We have done it from time to time if we just are really confused about a patient's kidney function. It is the gold standard, and it is a tool that is, it's a relatively simple assay, but it just takes time to collect it, and you're refrigerating urine for 24 hours, and no one enjoys doing it. So it's hard. And then getting at the other common form of clearance by the liver, estimating hepatic impairment and how that changes clearance for any drugs that are metabolized by the liver is even more challenging. All of our serum markers for liver function none of them are good proxies for how good a job the liver is doing with clearance and metabolization. So it feels a little nihilistic, but the changes in clearance are just really hard to estimate, unfortunately. Just know that it's variable, and the effect can be up or down. And I've put the formula for half-life here again, just to remind you that these changes in clearance and volume of distribution are going to affect your half-life. Okay, so we talked about clearance. Now, the other way that critical illness can affect pharmacokinetics is by changing the volume of distribution. And this is a little simpler because it's only ever going to increase. So volume of distribution will increase in critical illness. The question really becomes, how much does it increase? And how is it affecting the specific drug that we are using? So why does it increase? Many reasons. I've put a few of them here. So you get capillary leak when you have exposure to bacterial endotoxins, and fluid leaking into the interstitium is going to increase your volume of distribution. Low albumin is going to cause some capillary leak, and as you lose that fluid into the interstitium, that'll increase your volume of distribution. Any extracorporeal circuits like dialysis or ECMO, any of that plastic tubing that we're putting blood into and putting it back into the body, that the things lining those tubes are going to bind up some drug. Any surgical drains, extensive burn injuries, and then those with high transfusion requirements, all of these are going to increase your volume of distribution. Now, the most important metric for understanding whether that's going to be clinically significant or not is knowing what the drug in question's baseline volume of distribution is. And what I mean by that is that if you have a drug that has a volume of distribution of 50 liters, 100 liters, and you have a change of only 1 or 2 liters in your volume of distribution from your critical illness, the net effect of that is going to be pretty small. However, hydrophilic drugs, of which most are beta-lactam antibiotics, and most of our antibiotics are hydrophilic, tend to have a smaller volume of distribution on the order of 4 or 5 liters. And so that extra 500 cc's or a liter of interstitial fluid can actually make a difference. So again, a higher baseline volume of distribution, and you're relatively protected from this effect. Lower volume of distribution, you're going to be very sensitive to even minor changes in the patient's volume of distribution. And then a quick note again about protein binding. Any change in your serum binding protein, so again, like a decrease in albumin, are going to change the unbound concentration of drugs. So albumin is a negative acute phase reactant. It decreases in the setting of inflammation. As your albumin decreases, you will actually get more active drug because you have less albumin to bind to. Drug that is unbound is active. You get a higher proportion of unbound drug. So to summarize, pharmacokinetic changes in critical illness are complicated, but I think what we can say is that clearance probably increases early on, usually decreases later as renal and hepatic impairment develop. The volume of distribution will always increase. There's several mechanisms behind that. And the effect of that increase will depend on your baseline volume of distribution of that drug, with high volume of distribution drugs being protected from perturbations of your volume of distribution, and lower volume of distributions being more affected. That was a lot of information. We're going to stop talking about the effect of critical illness on pharmacokinetics and change gears to talk about one approach to dealing with this incredible amount of uncertainty that I think is pretty promising. And that's, Dr. Kenny tells me this is something that you guys are already doing, which is extended antibiotic infusions. So the rationale, to bring us back to this diagram I showed you earlier about the killing characteristics, is that beta-lactams in particular really depend on having the efficacy is a function of how long they spend at a concentration above MIC. So they have to be above MIC for as long as possible. And there's a little bit of wiggle room. If the tolerance for beta-lactams is pretty good. They don't have a very narrow therapeutic window the same way like digoxin has, where you can overdose someone easily. So you just got to get someone above that MIC. And you won't be that precise, but that's okay. The reason this is important is because if you have a patient in the ICU with septic shock, not only is it harder for the reasons we just talked about, to reach or to know what drug concentration you're getting, but it's also a lot more important. There's a lot of good data that failure to reach the MIC with beta-lactams is associated with an increased risk of death. And so it's just really, really important that we achieve this. Another reason that this is important is, like we talked about, these are hydrophilic drugs. They have a low baseline volume of distribution. So if you developed 2 liters of additional fluid in the interstitium, that's going to significantly decrease your plasma concentration, and you could be underdosing someone. So the use of an extended infusion strategy just allows for greater amounts of time above this MIC and gives you more wiggle room when you have a lot of unpredictability in your pharmacokinetics and pharmacodynamics. Just to put some figures to it, this is a simple figure showing the same drug given 4 different ways. The blue, the short one with a spike, is an IV pushover, or I guess it's IV over 1 hour. Green is over 4 hours, and purple is a continuous infusion. And you can see, or you can visualize what we all kind of know, that you get more of these spikes and troughs when you're giving it intermittently than with a continuous infusion. And those troughs are important. If you're falling below the MIC for too long, it can really inhibit your ability to treat a life-threatening infection. This is a bit busier of a graph, but I think it's important to show. This is 4 different models for antibiotic concentration on the y-axis and time on the x-axis. And the solid line is a typical intermittent dose of antibiotics with a dotted line, or sorry, with the dashed line showing your MIC. And what it's trying to outline is the effect that different dosing strategies have on the time you spend above MIC. And so A up here on the top left, this is saying, okay, what if we just increase the dose? So we get a higher trough, lasts a little longer, but you're only really increasing that time above MIC by about 25%. So you might ask, okay, what if we just give the drug more frequently? That's represented in B here. And sure, that might give you an increase, but only by, again, by about 25%. C is giving a longer infusion. Again, that gives you this 25% increase. And then D is what we're really doing with the extended infusion, is increasing the dose and giving it over a longer period of time. And you can see that just by doubling the dose, we get a peak that is about the same as with our intermittent strategy, and we get a much longer time above MIC. So this is really the physiologic underpinning for why this strategy was first kind of looked into and why we think it is effective. The downsides, there are a few. I mean, one, you need a dedicated IV, which sometimes we just don't have sufficient IV access in our patients. Beta-lactams have variable stability at room temperature, so that can be a limiting factor. And then just there is a higher rate of catheter-related complications. These are mostly pretty minor, infiltrations, and these are not, beta-lactams are not classically thought to introduce risk of skin or soft tissue necrosis, but it is a risk. So what's the evidence for this approach? We've talked about why it should be effective. Is it actually effective? So we know from pharmacokinetic studies that you're much more likely to achieve this threshold concentration above the MIC when using extended infusions. There is some emerging data that you face a lower risk of emerging antibiotic resistance, which makes sense. If you have a killing concentration for longer periods of time, it gives you less time to let the bacteria kind of learn some new tricks. The complicated thing is the studies on mortality are mixed, and this is probably a reflection of some study design issues about 8 or 9 years ago. I'm showing one of 2 meta-analyses with that concluded that there was a net effect towards favoring the extended infusions, here called prolonged. And then there's more recent data out of our institution that uses some more advanced methodology that would suggest a decrease in your risk of mortality. So just to summarize, the evidence is, we feel pretty confident that you're going to reach the concentrations you need more regularly. You're probably going to decrease your risk of resistance, and the jury's technically still out, but there is, I think, compelling data to suggest a decrease in your risk of mortality. So what is our approach at Hopkins? So our guidance is to prioritize extended infusions in patients who are critically ill, morbidly obese, or infected with a high MIC organism. We use them with these antibiotics, so piperacillin, tazobactam, cefepime, ceftazidime, meropenem, and ceftolozane, tazobactam. We give the first dose as an intermittent infusion, And then the extended infusion is given with the second dose. So for example, for piperacillin tazobactam, we would give a 4.5 gram bolus dose, and then the extended regimen would be that same dose, but given over 4 hours, every 6 hours. So it's maybe not a 24-hour infusion, but you're hooked up for 4 hours out of every 6. So it ends up being close to that. And this has been pretty widely adopted in our ICU, and we feel like we go to pretty significant lengths to obtain an additional IV if we need it to support this approach. Yeah, I mean, we've had a pretty good experience with it. So, Dr. Kenny, I'll turn to you. I have a couple knowledge check questions. Do you want to do those first, or do you want to have some question and answer or any discussion?